Prof. Rafeah, boleh kita mula ke?
Mr. Tan dapat masuk tak?
Okey, boleh. Assalamualaikum, good morning and salam sejahtera to all members of Fakulti of Medicine UKM and Hospital Chancellor Tuanku Mukhlis UKM. So I am Dr. Rafeah, the chairperson for today's CPC. So today's CPC is organized by the Department of Medicine, Faculty of Medicine UKM. So with me, there are two main presenters. Firstly, Dr. Saaidah Kamal Rodin from the Cell Therapy Center, Hospital Chancellor Tuanku Mukhlis, and Dr. Izzati Aziz from Department of Medicine. So with us, there are a few panelists. Dr. Tan Jin On from the Department of Orthopedics, Dr. Nur Wahyuna Rosli from Department of Pathology, and Dr. Juliana Fairuz Mata from Department of Radiology. So today's CPC basically emphasizes on the thought process from patient's presentation to a narrowed differential diagnosis, and subsequently we will focus on the final diagnosis. So without further ado, I would like to pass this presentation to Dr. Saaidah to start the presentation. Dr. Saaidah.
Okay. Assalamualaikum and very good morning. Welcome to CPC Medical Department. I'm Dr. Saaidah. I will start the CPC today with a case presentation. Mr. AF, 51 years old Malay gentleman with underlying type 2 diabetes mellitus.
Sorry, Dr. Saaidah, your slide.
Sorry. Sorry. Can see my screen?
Yes. Okay.
Okay. Assalamualaikum and a very good morning. Welcome to CPC Medical Department. I will start the CPC today with a case presentation. Mr. AF, 51 years old Malay gentleman with underlying type 2 diabetes mellitus, hypertension, dyslipidemia, ischemic heart disease, in which he underwent CABG in March 2023, and newly diagnosed chronic lymphocytic leukemia, small lymphocytic lymphoma in September 2023. He presented with sudden onset of upper and lower limb weakness for 1 day, in which initially he had sudden stabbing pain in his neck and upper back after waking up from sleep. Subsequently, he was unable to move both upper and lower limbs associated with numbness. Upon further history, he had intermittent neck pain for the last 3 weeks. Upon examination, patient was alert, conscious, full GCS, vital sign was stable, CVS S1, S2, lungs clear, per-abdomen soft non-tender, there is no hepatosplenomegaly. There is also no cervical axillary inguinal limb adenopathy. There was tenderness at the cervical region, and upon neurological examination showed patient having hypotonia and hyporeflexia of both upper limb and lower limb, with bilateral upper limb power 2/5 below the C4 level, bilateral lower limb power of 0/5. Patient also have reduced sensation below the C4 level. Otherwise, the Babinski is equivocal, anal tone is lax, bulbocavernous reflex present, perianal and deep anal sensation is absent. The initial investigations done, the full blood count show that patient having raised total white cell, in which there is a predominant of absolute lymphocyte count of 13.2. Otherwise, relatively, patient had normal hemoglobin and also platelet. The renal profile, apart from a bit raised creatinine, otherwise others are normal. The liver function test, electrolyte, calcium, magnesium phosphate, LDH, and coagulation is normal. So, from this brief history, examination finding, and also investigation, what further history and investigation would you like to obtain from patient? Second, state the differential diagnosis. And the third, outline the general management at this point. So I would like to invite Dr. Izzati, medical registrar, to share her thoughts regarding these 3 questions.
Assalamualaikum warahmatullahi wabarakatuh, and a very good mornings to respected professors, consultants, specialists, and my dear colleague. I would like to share my screen first so that everyone can run along with me when I'm presenting my lines of thoughts. So basically, for these patients who presented with a sudden onsets of acute presentations, and likely the pathology is in the spine. So with regards of the premorbid as well as the history, I would like to get a further history and details regarding any history of trauma that includes any history of fall, any history of massages. This could basically to lead us with regards either this is a traumatic causes or is it a pathological lesions that is happening in the brain, in the spinal cord. Second things I also wanted to know regarding any further history of the B symptoms, which includes prolonged fever for at least 2 weeks, night sweats for the past 1 month, any weight loss that includes 10% reduction in the baseline weight, any constitutional symptoms that could suggest any other malignancy that can lead to metastasis to the spine, any PTB contact, any latent TB, or any prior treatments of the tuberculosis and TB contact. This is basically to know at the disease progressions as the patient who has a CLL has immunoparesis and leads to recurrent infections, as well as the progressions of the disease. Third things I wanted to know about the background history of these patients, as he is diabetic. I wanted to know in particularly about the diabetic controls, what's the A1C level, what was the medications given to the patients, what's the SMBG likes, because poor controls of the diabetic is also a predisposition factors for the infections. And not only that, poor glycemic control as well as hypertensive and lipid controls is a risk factor for any vascular events that can lead to spinal cord infarct. This patient was recently underwent a bypass surgery. So prior to that, I believe he also underwent cardiac interventions, which includes coronary angiogram. So I wanted to know, is there any immediate complications following the procedures, any hospital-acquired infections, any catheterizations that can lead to catheter-related infections that can predispose to any bacteremia or any disseminations of infections. as this is rather in early presentations, I would also want to get a history of any features to suggest optic neuritis, where there is any blurring of visions, any episodes of TIA, any neurological deficits. Basically, my lines of thought at this point of time to rule out any demyelinating disease that can include multiple sclerosis or NMOSD, any family history of autoimmune diseases or any prothrombotic prior to this that leads to any phospholipid syndromes or even autoimmune disease such as mellitus. Apart from that, with regard specifically of the chronic, the CLL that patient was recently diagnosed, I wanted to know what are the presentations that leads to the diagnosis, what was the main complaint at that point of time, any history of blood transfusions, be it at the platelet transfusion or PEG cell transfusions, any recurrent infections prior to the infections, as well as I wanted to know what was the staging of the disease, any imaging done prior to these presentations. Second things with regards of the investigation, I further divided it
Okay,
into...
Dr. Izzati, okay, can
Yes,
you
Prof.
go back to the previous slide? Okay, Dr. Saaidah, would you like to inform Dr. Izzati the relevant history based on the questions that she posted here?
Okay. For this patient, there was no history of fall or trauma in this presentation.
Patient don't have any symptoms. Otherwise, the background disease control is quite fair. The diabetes, HbA1c is 7.1. Blood pressure and hyperlipidemia is fairly controlled in medication. Following history of severe intervention, there is no documented any catheter-related infection.
Sorry, Dr. Saaidah, your voice, can you speak a bit louder?
Oh, okay.
Oh, okay.
Okay,
regarding further history following previous CA video intervention,
there is no immediate communication post-procedure. There
there's no history of catheter-related infection.
And previously, patient
Previously,
don't have
patient
any
don't have
history of
any
blurring
history
of
of
vision,
vision,
TIA, or
TIA,
neurological deficit. So this is the first time patient having this complaint. Otherwise, no family history of demyelinating disease of immune disease. Okay. History that is of CLL, I will explain bit detail after this. There is no prior blood transfusion.
Thank you for the history, Dr. Saaidah. So basically, this patient has no other predisposing infection. So mainly now the lesion, I think it's basically in the spinal cord lesion, particularly in the cervical region. So yeah, coming to the imaging as well as the...
Okay, before that, okay, in the physical examination, is there anything else that you would like to know?
Yeah, I wanted to know, is there any palpable lymphadenopathy? As well as any other hepatosplenomegaly, to see is there any involvements of the extranodular as well as the nodal involvements.
What about the neurological signs? Are there anything else that you would like to elicit?
This patient already, as mentioned by Dr. Saaidah, the patient had a sensory level, so that's pinpoint further towards the spinal cord lesions.
Okay, apart from that, are there anything emergency that you would like to elicit in the physical examination?
The Babinski scans is already mentioned that it's outgoings, it's equivocals, and when the patient has absence anal reflex and deep anal sensations, so it's suggestive that it's a spinal cord like could be in spinal cord compressions, Prof.
Okay. Any abnormalities at the back that you would be looking for?
With regards of the physical examinations, I wanted, as the mentioned, patient has a tenderness in the cervical region. I would also want to check for, is there any step deformity that could suggest trauma prior to this, or is there any procedures done in the backs, such as a prior lumbar puncture that could lead to the predisposed to the infection as well, Prof.
Okay. So just based on the history and also the physical examination, so what would be your thoughts? Okay, what are the possible differential diagnoses before we go more on the investigations?
Actually, I put a slide for regarding the differential diagnosis here, Prof.
Okay.
So basically, for my lines of thoughts runs to it's either in infections, as patient having immunoparesis in a patient who has a CLL. Apart from that, most likely for this patient, it could be a spinal cord lesions. It can be either compressive or non-compressive lesions, or it could be broadly into inflammations or demyelinations disease. For basically for infections, particularly the most common causes would include pyogenics, mean carpet usually is a methicillin susceptive or methicillin resistant Staphylococcus aureus. Tuberculosis, as it's quite frequent in our populations. Apart from that, any viral or syphilis infections can also lead to a collections or even abscesses in the spine of spondylodiscitis. Apart from that, with regard to spinal cord lesion, the main things that I wanted to rule out as patient has multiple premorbid. Number one, it's a spinal cord infarct. Number one, or it could be any tumor, hematoma, disc herniations, or any spinal stenosis. And apart from that, in metabolic causes, however, usually in metabolic causes or toxic causes, rather than an acute presentation, the patient should usually has a more progressive rather than an acute presentations. And then the third things with regards of the differential diagnosis is an inflammations or demyelinations, in particularly in multiple sclerosis or neuromyelitic optica spectrum diseases, or even transverse myelitis or longitudinal extensive transverse myelitis, or even a post-infective or even paraneoplastic myelitis, Prof.
Okay, since the current presentation is quite acute, okay,
Yeah.
would you like to narrow down because you have a number of differential diagnoses?
Correct, Prof. So basically, with this patient, even though with a sudden presentation and acute presentation, mainly I think the most likely in this patient could be a spinal cord infarct or even a spinal cord compressions. Apart from that, another things that even though it's quite rare, there are cases documented in CLL where there is involvement of the central nervous system, particularly in the spines. So it's become leading to a cord compressions and cord edema as well, Prof.
Okay, so I think we go back to the results, and we would like Dr. Izzati to interpret the investigations listed by Dr. Saaidah earlier. Okay, yeah. So Dr. Izzati?
Yeah, by looking at this picture, this patient doesn't have any anemia or any thrombocytopenia. However, looking at the total white cell, the patient has a thrombocytosis, which predominantly
white cell count elevated would be
thrombocytosis. Leukocytosis. Leukocytosis with the total white cell count of 26,000, with predominantly of lymphocyte here, which is 13.2%. Apart from that, from the renal profile, the patient has a little bit of acute renal impairments, acute kidney injury with no electrolyte imbalances. And then the potassiums as well as the calciums and phosphate is also normals. Basically, I wanted to see what is the tumor burden, even though it's quite rare for CLL to have a tumor lysis syndromes, but I would still wanted to look for the parameters. Apart from that, the patient LDH is also normals, suggestive there's no hemolysis, and the INR is also normal, Prof.
Okay, so what further investigations would you like to order at this point?
So at this point of time, the history is quite acute. So I still wanted to rule out for infections, the basics investigations, which includes ESR and CRP to look for any elevations in the first place. And second thing, I would like to, based on the leukocytosis, I would also want to get full blood pictures for these patients. So particularly, I want to see is there regarding the morphology as well as the demonstrations of mature lymphocytes, as well as the evidence of smart cell, and particularly in a CLL, which is a pathognomonic for these patients. Further investigations that I would like to get with regards of the CLL, I would want to get a bone marrow and refine, not only to look for the morphology of the cells, but as well as to further subtypes and further subsequently to get immunohistostainings, particularly to look for positivity of CD5, 19, 20 as well 23, which is more specific for the CLL, Prof.
Okay, so in terms of the acute presentation now?
For these acute presentations, further things, I would like to get an imaging for these patients. I would start with a which is more readily available in our settings. The first one would be a simple cervical X-ray in AP and lateral view. Basically, I wanted to see is there any bony destructions or any loss in the normal curvature or any compressions. Apart from that, is there any soft tissue widenings that can suggest any collections or infections? And subsequently, it could lead us to a further specific imagings, can be either contrasted CT, MRI, to further delineate and to give us an idea with regards to what's going on for these patients, Prof. As well as in MRI, we can also see a spinal cord, any cord edema, or is there any hyperintensity to suggest any demyelinating disease or any acute infections, acute inflammations, Prof.
Okay, just now would you like to do bone marrow aspiration and refine at this point?
At this point, because the patients it's basically just to know the stage of the disease, but then for this patient, which is an acute cases, I will not do a bone marrow and refine first. I would rather get a to get the diagnosis first. This is as acute presentation. I would not want to miss any spinal cord compression for this patient, Prof, or any CNS involvements at this point of time.
Okay, so you won't be doing the bone marrow aspiration now and refine. Okay, what can you tell us the indication of doing bone marrow aspiration and refine in someone you suspected CLL?
So basically, to look for the marrow involvements where the patient has anemia as well as thrombocytopenia. However, at this point of time, the patient's hemoglobin as well as the platelet level are still within normal limits, Prof. Apart from that, it's basically just to look for any cytogenetics to give us an idea whether this patient is a high risk or non-high risk category, Prof. Basically for the staging, but I think at this point of time, not yet for the because a patient presented with something else which is acutely which is need to be addressed.
Okay, so as this patient is known to have CLL and now presenting with an acute problem, okay, what else would you be thinking about?
I still need to rule out central nervous system involvements of the infiltrations of the CLL. So I would like to proceed for a lumbar puncture. So basically from the lumbar puncture, not only to look for any gross morphology, gross appearance of the CSF, I would also want to look for any evidence of infections by the biochemistry, to look for specifically in the protein levels as well as the sugar levels. Going to be low in infections and protein level will be increased in infections. Apart from that, I also want to see for flow cytometry for the CSS to look for any abnormal lymphocyte and to give us any infiltrations of this abnormal lymphocyte into the nervous system.
Okay, as you know, CLL is an indolent disease. Okay, indolent lymphoproliferative disease or low grade. Okay, when someone present with an acute symptom like this, okay, would you consider something more aggressive?
Yes, Prof. Because if there's an involvement of the central nervous system, that means the disease is aggressive and the patient has to be treated urgently, Prof.
So, with regards to CLL transforming to an aggressive lymphoproliferative disorder or lymphoma, so what would be your thoughts?
Sorry, Prof?
Okay, because you mentioned just now, okay, so CLL is an indolent disease. So if it progresses to an aggressive, okay, lymphoproliferative disease, okay, what would be the term?
Riches transformations, Prof.
Okay, so
That's number one. I would also apart from that, I would also can see is there any a blast from the full blood picture, and then to look for any from the CSF. I think I could try to look for any the lymphocytes or any the flow cytometry, Prof.
okay, so you mentioned earlier that you would like to do some imaging.
Yeah.
Okay, so therefore I would like to invite Dr. Juliana to present the radiological findings.
Okay, Assalamualaikum. Thank you, Prof, for the invite, and especially thank you for the organizing committee as well. So let's move to our slides. So the outline of my presentation for today would be as such, as noted here. Okay, before we start, again, I'm going to torture Dr. Izzati here. Dr. Izzati, I'm calling you upon to describe again the X-ray. This is a cervical X-ray lateral view as well as AP.
Thank you, Dr. Juliana. So basically looking at these X-rays, thank you, Dr. Juliana, for putting the arrow. So basically, in this patient, I could see there is a destruction, bony destructions at the levels of 1, 2, 3, C4 and C5 here, as well as there is also widening of the soft tissues that could indicate any hematoma or any collection at this point of at this area. So I will need to further image to get further imagings to further evaluate regarding this area here, destructions over the levels of the black arrow as well as the soft tissue at the white arrow here.
Well, definitely that is what the arrow is pointing towards. Thank you, Dr. Izzati.
So, Dr. Izzati, can you roughly, so what level would that be?
C1, 2, 3, 4 here for C4, C5 for here.
Okay, Dr. Juliana?
Alright, thank you, Prof. So basically, the basics on the reporting of an X-ray, that mainly for undergraduates, yeah, everybody needs to know the lines. So vertebral line, we have anterior as well as posterior here. We have our spinolaminar line and posterior spinous line. So correctly, Dr. Izzati had already mentioned the obvious destruction of the C4 and C5 here. The one that I wanted to show you as well, that there is a subtle posterior bulging of the posterior margin of the vertebra here, as well as the anterior cortex is not well defined, may be caused by the destructive lesion that is coming from the C4, C5 as well, and definitely there is prevertebral space widening. Hence, normal width is actually 2 centimeter, and this is definitely quite marked widening of the prevertebral soft tissue. So in this case, this patient has underwent a CT to further characterize the destruction of the bony. So correlating with the X-ray, we are seeing quite similar bony destruction over the C4 and C5. There is this posterior bulging, and there is also, if you imagine of the line, posterior vertebral line here, there is also retrolisthesis, very mild retrolisthesis that is happening for this patient. The anterior cortex is destructive, and we are not be able to delineate the well-defined of the cortex at the anterior portion here, widening of the soft tissue that we mentioned before. There is also lytic lesion, as you can see here inside the vertebral body, that's causing the destructive of the bony lesion here. So keeping this in mind, so we are thinking of more pathological fracture or destructive lesion that is happening. Hence, this patient has underwent MRI. So the MRI, we have two sequence here. This is our sagittal view on STIR. Sorry, I moved this one further. And this is a post-contrast study. So on T2 is excellent for soft tissue, and we are seeing edema. So on this view here, C4 and C5, there is already bone marrow edema. the cortex here, we are unable to see. There is prevertebral soft tissue that causing displacement of this linear hypointense signal here. This is your ALL, anterior longitudinal ligament, and this prevertebral soft tissue has already anterior extension and already mass effect to the adjacent oropharynx anteriorly. Posteriorly, there is also soft tissue density. It causes impingement to the spinal cord. There is very marked spinal cord impingement posteriorly here. And on post-contrast, what we are trying to see is enhancement. So this prevertebral soft tissue as well as posterior at the epidural space here enhances as well. Let's look at the axial cut here. The axial cut is showing prevertebral soft tissue enhancement, and here at my arrow here, there is epidural enhancement that is causing significant spinal cord impingement on axial. So further down, there is also our favorite owl's eye appearance. So you can see here there is two foci of hyperintense signal on T2 on axial. This is the spinal cord region. So it resembles an owl's eye appearance. So this in MRI is significant of the spinal cord infarction or ischemia. So this patient has that as well. A bit on the topic. So bone marrow involvement with leukemia is very rare. Normally, if it were to happen in a younger child or pediatric patient, it mainly manifests as a diffuse disease. Or sometimes it could also be a normal finding on MRI. But a focal finding of bone marrow involvement is rarely observed, in patients with leukemia. So why is this case complex? Number one, this patient has a musculoskeletal issues. Some musculoskeletal issues can mean degenerative changes. It could mean infection. It could also mean malignancy, as this patient has an underlying malignant disease. So malignant bone lesion can sometimes resemble infection or inflammation. So MRI is not very diagnostic to see whether which is which. However, we do have our pathologists on board. So in these kind of cases, we undergo a culture and biopsy for more conclusive tissue diagnosis. So the radiological differential diagnosis, we are trying to touch all these four. So let's look at the image. So for degenerative end plate changes, we do commonly see it on MRI. This is our T2 sagittal MRI sequence, where you can see hyperintense signal at the end plate here, at the inferior end plate of L3, as well as the superior end plate of L4 and L5. So this end plate has this fatty signal intensity. This is only a fatty end plate changes, and it corresponds with modic changes of the degenerative. We can have three types of modic changes, which I'm not going to touch on this slide, but these are subsequently we are seeing the disc. The disc is also having abnormal signal intensity of hypointensity here. So overall, there is no bony destruction, so we are pointing towards a more degenerative end plate changes here. Alternatively, we are seeing this one as a spondylolysis or spondylodiscitis of the pyogenic. What is a bit different from the end plate changes of degenerative cause? This is irregular erosion. For the end plate, we are seeing more irregularity. The disc is also involved, and there is also fluid intensity, or there could be a abscess within, and this abscess or collection can go anteriorly as well as the epidural space, and also causing spinal impingement posteriorly. So if you can see here in MRI, also showing you on T2 as well as post contrast, you can see exuberant collection anteriorly, posteriorly. The disc is also having fluid intensity. The irregular margin or erosion of the end plates are exuberant and evident here. So this is a case of pyogenic spondylodiscitis. Let's look at other causes of spondylodiscitis. This is going to show you a tuberculous case. In tuberculous, quite similar. But however, the location differs. Mainly, it attacks the mid-thoracic or thoracolumbar more commonly than your lumbar or cervical region. You can also have these abscesses, paraspinal abscesses, quite large, and it is normally out of proportion from the vertebral involvement. It's hematogenously spread, and and bear in mind that we have to look for multifocality in tuberculosis as well. In adult cases, the disc is mainly quite spared as opposed to pediatric, which have a good vessel supply. It can lead to a very fast discitis features, but in adult, it will be the last one, and in tuberculosis, classically, the discs are spared until the final disease. This is just to show you the differences, what we are trying to look at for pyogenic as well as the tuberculous spondylolysis. How about spinal metastasis? Well, just going to show you the CT first. I wanted for everybody to see the lytic lesion within all the spine here. This is a case of a renal cell carcinoma who has multiple lytic bony lesion here, and this lytic lesion has caused a pathological fracture of the lumbar here. And we can see that the underlying bone is not healthy. You can see also the lytic lesion is also involving the posterior elements, and this also have a subtle posterior convexity as compared to the rest of the lumbar, which has this concavity, but this is a bit more convex. So it points towards that the bony mass has invaded the vertebral body and causes collapse, and this is the result of the invasion of the bone mass inside the vertebral body. Points to take pathological versus osteoporotic. How do we kind of see the clues? So definitely we are trying to see the multiplicity of the bony lesion. The white arrow is showing you the convex bulging that I've mentioned before. This is because of the bone metastasis has invaded the vertebral body, like I mentioned. Out of proportion bony destruction. Okay, and on MRI, what we are trying to look at is the abnormal synanticity within the vertebra that has replaced the normal fatty tissue or fatty marrow, which is in a normal vertebra, and this is an abnormal one which has a bony metastasis within. So this is some of the clues to further delineate whether this is a pathological versus an osteoporotic fracture in our case, such as in our case. Again, this is to show you our case. So retrospectively, what we are trying to look at is whether this is infection versus malignancy. But we then found out that it could either mimic each other or it can overlap each other. So in this case, there is also posterior bulging of the convex of the posterior margin vertebra here. There is also very exuberant paravertebral soft tissue anteriorly as well as the epidural space. So this inclined towards more pathological fracture. However, the superimposed infection can also be mimicking in this stage as well. So post-operation radiograph, the patient has underwent a radiograph, which will be more deliberate by our other panelists. And key points here that I wanted to mention is significant overlap of imaging of those documented as infection and those documented in malignancy. In such cases, a biopsy need to be ruled out in the absence of the certain evidence of a benign condition. And with that, thank you very much for your attention.
Yes, thank you, Dr. Juliana, for the explanation on the various imaging. Dr. Saaidah, would you like to tell us the other investigation results that you have at this point? Dr. Saaidah? Dr. Saaidah, would you like to present?
Yes.
Okay.
Yeah. Okay. Regarding the newly diagnosed CLL or SLL, patient actually had persistent lymphocytosis since 2020, but not on proper follow-up. He was initially referred from private center in view of incidental findings of lymphocytosis prior to CABG. Otherwise, he was asymptomatic. And upon the first presentation, patient had right cervical lymph node 2 × 2 cm, which is later biopsy revealed as SLL, small lymphocytic lymphoma. So on initial diagnosis, patient was CLL RY1 BNAT A, and at that point of time, the management is watch and wait. This is the full blood picture of the first presentation of the patient. The full blood picture show patient having 75% mature lymphocytes and also presence of smart cells. As I pointed here, this is the lymphocyte. This is the smart cells. So the initial impression from the full blood picture is most likely lymphoproliferative disorder towards CLL. We also proceed with bone marrow aspiration and refine biopsy. So for this patient, from the aspirate, refine, and also flow cytometry, it is in keeping with the CLL. Otherwise, the cytogenetic and also the fluorescent in situ hybridization for CLL panel is normal. Patient don't have any deletion of ATM, any TP53 deletion, deletion 13, and trisomy 12. As I mentioned before, patient had a right cervical lymph node biopsy, which consistent with small lymphocytic lymphoma, as the cells are positive to CD20, CD5, CD23, CD79A, and also BCL2. The Ki proliferative index is low, less than 5%. And the other thing that we do is a PET-CT, in which the PET-CT show patient having a few enlarged supra and infradiaphragmatic nodes with background metabolism. And the other thing that we notice from the PET scan is patient have diffuse hypermetabolism at upper rectum or rectosigmoid with luminal narrowing. So this patient subsequently do colonoscopy, and the HPE came back as normal. There is no evidence of lymphoma or Richter's transformation to more aggressive disease. So this patient was admitted to ortho spine ward.
Okay,
as
before
we-
that, okay, thank you, Dr. Saaidah. Okay, Dr. Izzati, back to you. So, can you tell us some of the confirmatory tests that you would like to perform, okay, following the history, physical findings, and also the investigations done so far?
So far, basically, from the full blood pictures, number one, demonstrations of the mature lymphocyte as well as a smart cell is already pointed towards directive, and subsequently is immunohistostaining, which is positive for CD 5, 19, 20, and 23 is also suggestive of CLL, Prof. Apart from that, the biopsy, which as these patients had undergone a biopsy of the lymph nodes, which shows positivity towards the lymphoma, the CLL as well, Prof.
What about the confirmatory tests for the current presentation?
Confirmatory test for current presentation is based on the imaging, as mentioned by Dr. Juliana just now. So the patient had a collections in the spinal cord which cause a cord compression. So basically in these patients, not only we need to rule out any infections and other things, we need to rule out any CNS involvements. Basically it's more aggressive forms of CLL that we need to be addressed, which already cause infiltration into the CNS system.
So what test would you do? Or what sample?
A biopsy of the lesion in the spine.
Okay. Therefore, I would like to invite Mr. Tan to present the initial findings and also the initial management of this patient. Mr. Tan?
Good morning, all. Give me some time. I will just share my slide. Can you all see?
Yes.
Okay, so thank you for the invitation. So I'll be presenting on the what did we do upon presentation of the patient. So the patient actually presented to us and was referred to us from Hospital Kajang on, I think, early October. And upon receiving the referral, we acted on it immediately, and this was his neurology findings on presentation. As you can see, he has a complete spinal cord insult, with the last neurological level being at C4, and there was a complete paralysis of bilateral upper and lower limbs with loss of perianal sensation as presented. This was the X-ray as described by Dr. Juliana, and in view of patient having an acute neurology, I think it was less than 12 hours before it started. We had to go in for emergency decompression and stabilization. These are the findings, MRI findings and CT scan findings, which was described by Dr. Juliana. So what we did was we went in for anterior cervical corpectomy of C4, C5, and C6 on the 11th October, on the day of admission. And intraoperatively, we found that the bones, there was a diseased wound of C4, C5, and C6, worse at C5. There was a past discharge from the affected disc spaces. There were a lot of extradural tumor tissue which were adherent to the spinal cord. The quality of the bones were poor, and after doing the corpectomy from the front, we sent the bone and tissue for histopathological examination, culture and sensitivity, and TB workup. So this was the immediate post-operative X-ray. There is a cage in the front to reconstruct the C4, 5, and 6, which was supported by a plate. This is immediately post-op day 1. Patient actually recovered quite a lot, because when he presented to us, he was literally power zero. He was unable to lift up his shoulders, his elbows, and his hands. This is after our first day of surgery. The next morning, you can see he is actually doing relatively well. He regained some movements over both upper limbs, and he was able to sit up on a reclining wheelchair. So I think the key to this is what we want to highlight is early decompression for patients presenting with acute spinal cord injury gives a good outcome. So intraoperatively, these samples came back as infection, TB, and also the HP showed malignancy, acute or chronic inflammation, and small lymphocytic lymphoma. So this is our, we initially thought this was a triple pathology, and we referred the case to the medical teams.
Okay, thank you, Mr. Tan. I think I will call upon Dr. Wahyuna to present in more detail on the histopathological findings of the biopsy.
So I
Share
have
my
to stop my screen sharing.
I have to wait for Mr. Tan to unshare. Okay.
Yeah, and sharing. Sorry.
Thank you. No worries.
Okay.
Okay. So let me just put this in presentation mode. Okay. So we received specimens from this patient, which was labeled as tissue C5, bone C4, and bone C5. So as for the tissue C5, it only shows fibrocollagenous tissue with some acute and chronic inflammation. There was no granuloma seen, so I'm not going to show that. So we're focusing on the specimen of interest, which is bone C4 and C5. So this is the lowest magnification for from the bone C4 and C5. So you can see the bony trabeculae, the pink area that I'm showing with my laser pointer,
and in between the pink trabeculae, we have marrow spaces. So, so these marrow spaces is considered hypercellular. So, just for comparison with the normal bony tissue that we receive, we expect to see some fat as well as hematopoietic cells in between. And as a patient gets older, we have more fatty tissue, we have more adipocytes in between the hematopoietic cells. But if you can see from our patient, there's not much fatty tissue at all, no adipocytes, but instead we have very cellular marrow spaces. And then we can actually see there are areas which are appears more cellular than the rest. As I pointed, it looks more blue than usual. And as we go on higher magnification, this is what we got from the patient. And as for comparison, this is from a normal bone marrow. Okay, so for this patient, we see hypercellular marrow spaces with neoplastic cells which are discohesive. Okay, very discohesive and composed of small lymphocytes. If you compare with your normal marrow, you should expect to see all the hematopoietic cells in the different lineages and then different stages of maturation. But over here, it's mainly just blue cells. Okay, and then when we further try to determine the lineage of these cells, okay, so it's just the lymphoid cells are small, monomorphic with uniform round nuclei and very scanty cytoplasm, not much cytoplasm at all, very blue. So when we try to determine the lineage, whether it's B or T, it is positive for CD20 and CD79 alpha, and they are actually negative for CD3. So more of the small neoplastic cells are positive for B cell markers, and the CD3 just highlights small T cells in between the neoplastic lymphoid cells. So next, when we determine the lineage, we also want to know how aggressive the neoplastic lesion is. So we perform proliferative marker, which is Ki67. So here it shows that the it will stain brown. So in this case, it is less than 5%. So the proliferative index is low. So next, now we know that this is a B cell neoplasm with small to intermediate cell morphology. So we will have to think about the differential diagnosis and whether it can be mantle cell lymphomas, small lymphocytic lymphoma, or CLL, follicular lymphoma, or marginal zone lymphoma. So we will perform some more markers. So first is CD5. So CD5 is positive in this patient. And once it is positive, it can either be mantle cell or CLL. So we can do CD23 and cyclin D1 to further delineate. And in this case, the neoplastic cells are positive for CD23 and they are negative for cyclin D1. Therefore, with all the immunohistochemical markers that it is positive for, which is CD20, CD79 alpha, CD5, CD23, and I didn't show that this case is also positive for BCL2. The overall picture points towards small lymphocytic lymphoma, consistent with small lymphocytic lymphoma and chronic lymphocytic leukemia. Okay, that's all. Thank you.
Thank you very much, Dr. Wahyuna. So I think with regards of time, okay, I would like to call upon Dr. Saaidah to wrap up on the case.
Okay. I will share my screen. So the final diagnosis of this patient is spinal cord compression, secondary to CLL, SLL stage 4, with bone and spine involvement, and also MSSA spondylodiscitis. As pertaining to the spinal cord compression, patient had underwent a decompression surgery. And as for the MSSA spondylodiscitis, patient was started on IV cefazolin 2 gram TDS and also doing intensive limb physiotherapy in orthospinal ward. So subsequently, the power of
Sorry to
bilateral upper limb
interrupt, Dr. Saaidah. Okay, so what do you think renders this patient, I mean, why did he get the MSSA spondylodiscitis at the same time?
This patient, basically, patient with CLL or SLL, they pretend to have low immunoglobulin level. So most of the time, patient usually have hypogammaglobulinemia. Patient will have immune paralysis and prone to recurrent infection.
Okay.
So it's pertaining to the underlying CLL or SLL.
Okay. Continue.
Okay. Okay, so progress of the patient. Patient had neurological improvement post-op with intensive physiotherapy. As for the duration of antibiotic is 12 weeks, combination of IV and oral. And in the ward, patient completed 8 weeks of IV cefazolin, and then upon discharge, he was given rifampicin and also doxycycline. So we also did a MDT with spine oncology and also hemato team. For the spine, they doing intensive physiotherapy and rehab. We discussed with oncology regarding role of radiotherapy. So since CLL, SLL is radiosensitive, the oncology team given radiotherapy to spine C2T1, 20 gray 5 fraction on the 27th November to 1st December. Otherwise, from hemato point of view, we want to reassess patient post-completion antibiotic, and we will discuss with patient regarding the definitive treatment for the CLL or SLL. Definitely either chemoimmunotherapy or with the era of the novel agent, we will discuss regarding Bruton tyrosine kinase inhibitor. Patient was discharged with regular physiotherapy and TCA daycare hemato 2 weeks to review. So I will just proceed with a brief overview of chronic lymphocytic leukemia or small lymphocytic lymphoma. So it is an indolent malignancy in which it is a slow growing. Sometimes patient is asymptomatic and most of the time patient not require any urgent treatment. So CLL, SLL is defined as a monoclonal lymphoproliferative disease characterized by increased proliferation and accumulation of morphologically mature but dysfunctional B lymphocyte. The primary disease sites usually include peripheral blood, spleen, lymph nodes, and also bone marrow. So what is the difference between CLL and SLL? According to the 2022 WHO classification, CLL and SLL is considered as single entity as both originate from B-cell lymphocytes but present with different manifestation depending on where the abnormal cells are found. So to make it easy, for CLL, the abnormal B lymphocytes are present in the peripheral blood or marrow. For SLL, the abnormal B lymphocyte usually found in the lymph nodes. So according to the 2022 lymphoid neoplasm classification from the WHO, CLL is defined as low-grade lymphoproliferative neoplasm with 5 or more times 10 to the power of 9 per liter clonal B cells in the peripheral circulation that express CD5, CD19, CD20, and also CD23. Usually, most of the time, CLL are preceded by a pre-malignant condition known as monoclonal B-cell lymphocytosis, in which there is less than 5 times to the power of 9 clonal B cells in the absence of lymphadenopathy, organomegaly, and also cytopenia. So for the diagnosis and staging workup for the CLL, SLL, back to the basic history, physical examination. So for the history, it is important to ask patient regarding B symptom, which is fever, loss of appetite, significant loss of weight, 10% within 6 months, and also night sweat. And then from the physical examination, we have to look for hepatosplenomegaly. It is important to staging the disease, and also the presence of the lymphadenopathy. Otherwise, other than that, complete blood count and differential. And then, as I mentioned just now, upon initial diagnosis or pre-treatment evaluation, we have to send serum immunoglobulin because we have to look at the immunoglobulin level of the patient. Most of the patient tends to have hypogammaglobulinemia and immune paralysis and tends to have recurrent infection. So as part of the treatment, we can give supportive immunoglobulin IVIG for this patient. Other than that, if the patient have anemia, we have to look for any evidence of hemolytic anemia. Apart from the direct antiglobulin test or CUM test, we can send other hemolytic markers such as the LDH, retic count. And then what I want to stress is as you can see, the biomarker here, we have to send upon diagnosis and staging the TP53 mutation or deletion 17p by FISH or by the NGS. And another thing that we need to know is the immunoglobulin heavy chains and also presence of complex karyotype, as these three biomarker is associated with poor prognosis of CLL or SLL. So other than that, as you can see here, the marrow aspirate and biopsy, it is not necessarily due during the initial staging and diagnosis, because most of the case of the CLL can be just diagnosed by flow cytometry. So usually we will do the bone marrow aspirate and biopsy if the flow cytometry is inconclusive or patient have any unexplained cytopenia. Apart from that, during the diagnosis and staging, we have to do viral screening, including hepatitis B, C, CMV, and HIV. And as you can see here, radiological imaging, whether CT scan or PET scan, is not usually indicated during the initial staging and diagnosis. Usually, we will do the radiological imaging if clinically indicated. For example, we suspect patient have Richter's transformation. There is a transformation from indolent to the more aggressive lymphoma. So this is, as I mentioned before, the diagnosis of CLL by flow cytometry, and bone marrow biopsy is generally not required. SLL is ideally confirmed by lymph node biopsy. So staging of CLL, we are using the RAI and BNET staging. As you can see here, for the BNET, we have A, B, C. It's easier to remember. BNET A, you just remember less than 3 involved lymphoid site. B, more than 3 involved lymphoid site. BNET C, patient will have anemia and thrombocytopenia. For the RAI system, we classify patient from RAI 0 to 4, and then stratify into low, intermediate, or high risk. And it's not so difficult to remember. For RAI 0, patient will have lymphocytosis. RAI 1 plus lymphadenopathy. RAI 2, patient has hepatosplenomegaly. RAI 3, patient will have anemia. RAI 4, patient will have thrombocytopenia. So SLL staging, we are using the same staging as other lymphoma, which is Lugano modification of an Arbor staging system. As you can see here, stage 1, stage 2, 3, and 4. So risk stratification is important for patient CLL. So for the risk stratification, we use the CLL International Prognostic Index. As you can see here, the most two up here is the poor prognostic factor, which is deletion 17p on FISH or TP53 mutation, and also unmutated IGHV gene. So what is the usage of the CLL IPI score? We classify patient into low, intermediate, high, or very high. Usually, patient with high or very high CLL IPI score tends to be treated early, so we can predict time to first therapy for those type of patient. So when to treat? Not all CLL or CLL patient need to be urgently treated, as it is an indolent. Most of the patient is asymptomatic. So what is the indication for treatment? So according to this 2018 International Workshop on CLL, there are parameters that can guide us to start treatment for patient. So for example, the first one, as you can see here, lymph node, massive enlargement of lymph node more than 10 cm, progressive or symptomatic, and then presence of massive hepatosplenomegaly more than 6 cm and progressive or symptomatic, and then patient will have constitutional or B symptoms. The circulating lymphocyte count usually progressive more than 50% over 2 months period, or lymphocyte doubling time less than 6 months. And then other than that, patient will have worsening thrombocytopenia, anemia, or progressive marrow failure as cytopenia above. So another thing is extranodal involvement. For example, patient will have skin, kidney, lung, or spine. As our case today that we discussed in CPC, the patient have CLL, SLL with spine involvement. So patient was warranted for treatment. So is it common, CLL or CLL with spine involvement? Actually, spinal involvement in CLL or SLL is very rare. So far, only 2 cases of spinal cord compression attributable to an extradural solid mass composed of leukemic cells have been reported. So spine involvement should be considered in patient with back pain and also neurological symptoms. Sometimes it is quite difficult to differentiate between spine involvement and also infection. So histology is necessary to confirm the diagnosis. So I will just share the 2 case report in which a patient came in with spinal cord compression. The first one published in the Journal of Clinical Pathology in 1992, a cord compression, a rare complication of CLL. In this case report, they demonstrate a 66-year-old gentleman with CLL, RI2 and BNAT-P, unknown cytogenetic and molecular abnormality. After 22 months of diagnosis of CLL, patient suddenly developed lower back pain with paraplegia and paresthesia at level 1 level. So patient underwent emergency laminectomy and excision of the lesion 6 × 4 cm, which later turned out as a CLL. Following the operation, patient had local radiotherapy and also systemic chemotherapy, CVP for 6 cycles. Subsequently, patient have improvement in the neurological function. The second one is the spinal epidural compression in CLL, which is reported in the Cancer Journal 1989, in which they demonstrate a 78-year-old female with CLL, RI3 and BNAT-C. A patient after 6 years of diagnosis developed paraplegia, paresthesia of both arms and also double sphincter paralysis. For this patient, they manage conservatively as there are many factors such as advanced age, multiple comorbid. So for the acute management, they give high dose steroids, antibiotics, and also radiotherapy. Following radiotherapy, patient not a long time after that, patients demise. So I will just brief regarding the treatment for the patient following the IWCLL criteria to start treatment. So as I mentioned before, we have to know the TP53 status of the patient. Then, as you can see here, we divide the patient into 2 groups, TP53 positive or TP53 negative. So as you can see here, for the TP53 disruption, from the guideline of the CLL treatment algorithm 2022, they suggest the use of Bruton tyrosine kinase inhibitor plus minus CD20 monoclonal antibody, which is obinutuzumab. As you can see here in the box, the choice of the BTKI, they suggest and they preferred the second generation of BTKI, which is acalabrutinib or zanubrutinib. As because from the previous study and recent ongoing clinical trials, there is a less toxicity and side effect with acalabrutinib and zanubrutinib compared to ibrutinib. So now we went to the dose with no TP53 mutation. So we have to look for the unmutated IGHV gene or mutated immunoglobulin heavy genes. So as you know, this is a poor prognosis. So for this type of patient, if the patient is fit, the guidelines suggest combination of BTKI plus BCL2 inhibitor, which is ibrutinib and venetoclax. Or we can give combination of BCL2 inhibitor, venetoclax plus obinutuzumab, anti-CD20 monoclonal antibody, or we can combine the BTKI plus obinutuzumab. For those with the mutated IGHV gene who is fit, unfit, or unmutated, unfit, the recommendation is venetoclax plus obinutuzumab or BTKI plus obinutuzumab. Okay, so summary and learning point. The importance of identifying spinal cord compression and needs to be treated as emergency. And then the cause of the spinal cord compression needs clinical imaging and HPE correlation. CLL, SLL with bone or spine involvement is very rare, however, need to be considered. And usually the management will involve multidisciplinary approach for the management. And for this CPC, I would like to highlight on the novel agent, which is the oral targeted therapy, Bruton tyrosine kinase inhibitor, and also BCL2 inhibitor. So take home message regarding the role of novel agents in CLL treatment. Before there is a novel agents, previously for the CLL, we treat with chemoimmunotherapy, in which most of the patient they will receive rituximab combination with either chlorambucil prednisolone or RFC or arbendamustine. So now in the era of presence of the novel agents, the guidelines suggest that we use the novel agent for the treatment of the CLL. So this has changed the treatment landscape for patients with CLL. As I mentioned before, in the algorithm, we give combination either BTKI inhibitor or BCL2 inhibitor plus minus anti-CD20 monoclonal antibodies. So from this novel agent combination with the anti-CD20 monoclonal antibody have shown from the previous trial and also current clinical trial ongoing that the combination of this medication has improved outcomes in patients with CLL even among those with high-risk features. Okay, that's all.
Thank you very much, Dr. Saaidah, for the summary of the case and also outline of the disease itself, CLL with spine involvement, and subsequently the relevant investigation, risk stratification, and management. Okay, I would also like to thank Dr. Izzati, the main a person on the hotspot for today, and also the other panelists, Mr. Tan, Dr. Juliana, and also Dr. Wahyuna. So before I end this CPC, I would also like to wish everyone again, hope it's not too late to wish everyone Happy New Year. Okay, it's a leap year this year. Okay, and thank you very much. So we will proceed with a few Kahoot questions.
Okay, thank you Prof. Saya akan share Kahoot